Today we are here to present the revival of Aztreonam with Avibactam, redefining the antibiotic treatment, the webinar. And for today, I would like to welcome moderator Dr. Venkat Ramal Kola sir. Sir is a clinical director, consultant intensivist in critical care, Yashodhara Hospital, High Tech City, Hyderabad. Sir, over to you.
Yeah, thank you. Thank you, the Poland Healthcare Private Limited, for bringing this webinar. And very interesting and pertinent topic for current antimicrobial concerns. And to initiate this, we will have a session of directed talk by Dr. Nitin Sinde. He is the Associate Director of Infectious Disease and Internal Medicine, Max Super Specialty Hospital, Nagpur. He carries his rich experience and interest both in infectious disease, metabolic health, and longevity functional medicine. Has been member of multiple societies, including the IDSA, European Society of Clinical Microbiology and Infectious Disease, and CIDS. So over to you, Dr. Sinde, for your revival of Aztreonam with Avibactam. As we know, Aztreonam was available with us as a monobactam for all the gram-negative covers, including the Pseudomonas in a difficult times. But over a time, this monobactam has lost its charm and its luster because of the resistance, including the ESBL, which can destroy this. But again, now NDM and Avibactam. So these two brought us Aztreonam back in combination. So we love to listen from you regarding this revival of Aztreonam. Over to you, Dr. Nitin Singh.
Yeah, thank you, sir. Thank you, Team Poland, and thank you, sir, for this introduction. So wasting much of time, I'll go ahead with this topic. And I think everybody is curious, including me. I was also curious how this we can combine Aztreonam with Avibactam when we already have ceftazidime, Avibactam, and Aztreonam combination used in past couple of years, and which is actually losing luster. So what next? So there are always questions in the science, and we try to solve those questions with innovative answers. So this is that small attempt of answering these questions. So if you see, this is the pattern. This is a different type of beta lactamase in enterobacteria. So you have class A, class B, class C, and class D beta lactamases which are present. I have tried to be simple as far as possible, because a lot of people find this very confusing and a lot of people do not understand, and basically that confusion may lead to using inappropriate therapy in many patients. So I've tried to be very simple in this approach. So now you have 4 types of beta lactamases which are there, and all last 5 years we are very worried about OXA 48, OXA 23, KPC, GES, NMCA. So fortunately, the beta lactamases which we are dealing every day is basically CTXM, TEM, and OXAs. So and AMC, obviously. So 3 to 4 important enzymes which we are battling, and the 4th one is amyloid class B, which is NDM. So we already found answers on class A, class C, and class D blockers. So class A, class C, class D, all 3 enzymes are addressed with our novel combination. So these are the more important enzymes. So all these 3 classes of enzymes were targeted by ceftazidime and Avibactam, which is a recent molecule which got an European EMA approval in 2015, and in India we started using in 2019, and we're elated with its introduction in our armamentarium, because this is a drug which is basically used for complicated urinary tract infection. So we are not worried hospital acquired pneumonia, complicated abdominal infections, pyelonephritis, and ventilator associated pneumonia. So our worry with OXAs and ESBLs, we thought that it is ended, and we had initially in the beginning we had very few bacteria, specifically Pseudomonas, which is co-producer of NDM. So we have bacteria which is producing OXA, but only 50% of them or 30% of them were producing NDMs, class B, amyloid class B. So we were okay, and we were very happy with the results of ceftazidime Avibactam. And ceftazidime avibactam, one of as a completely new molecule in this program, and it was very simple. So you have an avibactam, which is a beta lactamase inhibitor, which covalently binds and inactivates beta lactamases. So and it prevents ceftazidime to hydrolyze. So ceftazidime has a prolonged action. Ceftazidime is a fourth generation cephalosporin, and it enters into the cytomembrane of drug-resistant bacteria. It binds with PBP, and it inhibits the synthesis of bacterial cytopeptidoglycan. So that results into cell lysis and death. And Kazavi had a significant activity against Klebsiella pneumonia, capices, and OXA48. So all of us heaved a sigh. We had fantastic molecule with us, and which is powerful ceftazidime, which was made powerful by Avibactam, and we have started using it in MDR Klebsiella and MDR Pseudomonas. Then we had a problem. Then we found that a couple of our Pseudomonas and Klebsiella, they also co-produce amylar class B beta lactamidase. So the most common beta lactamidase, amylar class B, which we see in India, is NDM, New Delhi metalloproteinase. So what do you do with this type of organism? So then we found out, yeah, we can use another drug, which is Aztreonam, which can actually which can work in the presence of NDM. So we started doing synergy testing. So you do a synergy test, and if you find synergy testing is positive, probably you add Aztreonam in those patients. So now it is very, very technical, very, very rational. You start ceftazidime avibactam, test those pathogens for doing carba, do look at their genes, whether it's an ESBL, whether it's an MC producer, whether it's a CTXM, it's OXA, KPC, and if it is NDM positive, please use Aztreonam. So that was a simple thing. So synergy test basically picks the inhibition of serine beta lactamase as well as metallo-beta lactamase. So NDM is a metallo-beta lactamase which requires zinc ion for its functioning. So we evolved to this, and we were happy that we have found Aztreonam, which can be combined with Kazavi, and we can probably got over to all the pathogen which is causing multi-drug resistance. However, what happened over the period of time, as the world started using more of ceftazidime avibactam, so our problem with OXA has come down, and now we are facing the problem with MBLs. So we have so many MBLs right now, which is basically has become a Achilles heel to treat the organism or to treat the infection. So we have so many organisms which is primarily producing MBLs, and at the same time they are also having KPC or OXA in different areas. So in India we have majorly NDM, and then Southern Europe this Verona integrin VIM, and in East Asia there's imipenemes which are circulating in those countries. So MBLs become primary headache, and ESBLs or class A, class C, and class D beta lactamases become a secondary problem. And that's the reason here Aztreonam is actually becoming an important drug, because we know that MBLs are not inhibited by any other beta lactamase except Aztreonam. But at the same time, Aztreonam is a very interesting molecule. It is degraded by other beta lactamases like AMC or ESBL, and which are frequently co-produced by MBLs like Pseudomonas and Klebsiella. So the combination of Aztreonam with Avibactam actually restores Aztreonam activity against bacteria. So if you use Aztreonam, it is a very, very narrow spectrum antibiotic. But if you combine with Avibactam, it becomes a little broad spectrum. I won't say very broad spectrum, but it becomes a little broad spectrum in the term that it can actually neutralize a lot of other pathogens. So the Aztreonam becomes an interesting discovery, or I would say rediscovery. And there are a lot of literature started coming between 2019, and there's a lot of papers now coming about the combination of Aztreonam and Avibactam, and Aztreonam with obviously combination with a lot of other molecules. At the same time, there's a lot of discussion about combining Avibactam with other molecules like ceftaroline and ceftazolone. So Aztreonam is basically very, very structurally similar to ceftazidime, and its spectrum of activity is similar to third generation cephalosporin. Its elimination half-life is actually less than 2 hours. So it's a short-acting drug, and you have to actually give it frequently during the day. So usual dose is 0.5 to 1 to 2 gram, and 3 times a day, or 4 times a day, or sometimes you can use it 4 times a day also. So generally it is given 2 gram 6 to 8 hourly in severe systemic or life-threatening infections caused by Pseudomonas aeruginosa. So it is the bactericidal activity is limited to aerobic gram-negative rods. It has excellent activity against all Enterobacteriaceae, specifically Pseudomonas aeruginosa, but it has no activity against any of the gram-positive bacteria or anaerobes. So, being a narrow spectrum antimicrobial, you cannot use it as an empirical therapy in many situations. Traditionally, it is very useful in the patients who cannot tolerate penicillin or who have allergy to penicillin or cephalosporin. It is a drug of choice for those patients. It is traditionally been used in pneumonias, hospital-acquired pneumonias, complicated pneumonias. It is being used in meningitis. It's very interesting. It does not achieve a lot of concentration in brain. That it is still effective in meningitis. It is used in gram-negative sepsis. It is definitely used in urinary tract infections and osteomyelitis caused by gram-negative pathogens. So this is a diagram which depicts the power of Aztreonam. So if you can see, Aztreonam is not inhibited by MBL. So all other antibacterials like cefepime, piperacillin, tazobactam, meropenem, ceftazidime, avibactam, ceftriaxone, tazobactam, imipenem, rilebactam, meropenem, vaborbactam. So all these antimicrobials are neutralized by MBLs. However, however, Aztreonam has a strong wall. And then you have avibactam, which is a strong wall against all ESBL producers and some of the AMC co-producers. So the another beta-lactamase inhibitor in combination with Aztreonam is Avibactam. So Avibactam is one of the very novel beta-lactamase inhibitor which was discovered lately, and it is a non-beta-lactam molecule, and it does not contain a beta-lactam ring. And it is very interesting, very interesting molecule, because all other beta-lactamase inhibitors like sulbactam or clavulanic acid or tazobactam, they are called as suicide inhibitors, because once they attach to beta lactamases, they themselves get neutralized. So there is the action of the last generation or previous generation beta lactam inhibitors is very specific and limited. So but avibactam is completely different. Avibactam is a reversible binder of beta lactamases, so it attaches to the enzyme, beta lactamase enzymes, and then it gets regenerated again, reactivated again. It deactivates the enzymes and reactivate again. So it is very interesting, and because of its tendency to react covalently and reversibly with beta lactamases, it is one of the very important and effective beta lactamase inhibitor available in the medical therapeutics. So if you use Aztreonam and Avibactam together, there are a lot of problems. So primarily here, the main drug is Aztreonam, and Avibactam is basically there to protect Aztreonam. And both the drugs has some similarities and some discrepancy in their pharmacokinetics. So if you see, the volume of distribution of Aztreonam is 19.6, Avibactam has a little higher VD. Cmax of Aztreonam is very high, whether Cmax of Avibactam is little low. T-half is almost similar of both the drugs. And AUC, if you see, there's a huge difference. Protein binding, huge difference. And elimination, there's a little bit of difference in these drugs. So there's a lot of pharmacokinetic discrepancy. And that is the reason combining these two drugs is very challenging. So right now we are giving these two drugs separately to the patients, and what happens to these drugs in the body and how they bring their residual effect is very interesting, and it is very peculiar to understand. In preclinical studies, they really decide the dose of Aztreonam.
Can we mute all the other participants?
बड़ी भाई पास तेरे भाई पास पड़ी हुई है यार नहीं
Can we mute?
इससे जुड़वा दूंगा यार चलना तो है ही यार भाई बात हो गई मवैया में है
The digital team, can we mute all the participants except Dr. Nitin?
All right. So for Aztreonam, it is challenging to decide a concentration which will be bactericidal. So a time above critical concentration of the drug as a proportion of the regular dosing interval, which is represented here with T, and F basically denotes the free drug levels. So FT more than MIC of 60% is basically a level where Aztreonam becomes a bactericidal for its action. So to decide how will you really decide? So you first decide the dose of Aztreonam, and for that the PKPD target here is a percentage of T which is more than MIC of 60% or greater. So most beta-lactam inhibitors are not antimicrobials. So here the main problem is deciding the dose of Aztreonam. The principles PKPD indices are different, and deciding the dose of Avibactam, the PKPD index is completely different. So if you want to decide the dose of Avibactam, because Avibactam is not itself an antibiotic, and you cannot call it that. You cannot call it as a its effect as a bactericidal effect. You have to really depend on the different PKPD parameters. So its antibacterial ability is basically depends on its concentration required to restore its beta-lactam activity. So that can be decided by its threshold concentration, which is called as CT. And Avibactam displays linear enzyme kinetics with rapid and diffusion limited binding to the enzymes. So you have a lot of preclinical data which reveal that the percentage FT more than CT is a PKPD index to support the clinical efficacy of Avibactam in combination with ATM. I will tell you why I am talking about this in the next few slides. So the PKPD index for Aztreonam is different. The PKPD index for Avibactam is different. So if you want to find out a joint PTA, the joint PTA means probability of attaining the therapeutic target. So if you want to achieve a therapeutic target by Aztreonam and Avibactam, you have to have those cutoffs. So a cutoff for Aztreonam is 8 microgram per ml, and cutoff for Avibactam is 2.5 microgram per ml. So these are the pharmacokinetic cutoff, and based on this, you have to design the dosing in preclinical studies. So based on these indices, we can definitely see that the pharmacodynamics of Avibactam is more of time dependent rather than a concentration dependent. So that is the reason you have to give Avibactam in prolonged infusion along with Aztreonam. So you cannot miss these things, because if you do not give Avibactam along with Aztreonam in prolonged infusion, you can basically do not achieve its PKPD indices, and a lower compliance to PKPD indices will actually can result in dramatic change in the bactericidal capacity of these two drugs. So we've been seeing that when we prescribe Aztreonam and Avibactam, people may just give Avibactam, do not give Aztreonam. People may just give Aztreonam, do not give Avibactam, or the infusions may be given at a different point of time. So the whole this PKPD discussion is about giving these drugs together and in a prolonged infusion. The recommended dosing is this. So both the drugs are cleared by kidneys, and it is very important that the doses are properly titrated in the patients who have renal dysfunction, and a lot of patients in the ICU have augmented renal clearance. So in those cases also, it is important that we have to see how doses can be escalated in these cases. So the toxicities are not very common with Aztreonam and Avibactam. However, Aztreonam can cause mild elevation in liver enzymes, and in sick patients that can actually cause a lot of problems to the patients. Or you may not understand why there is elevation of enzymes if the creatinine clearance is very low and the dose of Aztreonam is not properly titrated. So there is always problem with the patients who are on intermittent hemodialysis or on CRRT, because the dose will remain dynamic in these cases. So the initial evidence about this particular combination came from two big trials. The first trial was the Revisit trial, which is a phase 3 prospective randomized multicenter trial, which was conducted in 422 patients. and the most of the patients had complicated intraabdominal infections or VAP, and 422 participants were randomly assigned a 2:1 ratio to receive either ATM AVI with or without metronidazole or meropenem with colistin, with or without colistin. So the results of this trial were very encouraging. This was an Israeli trial, and they could find that the patients who received Aztreonam Avibactam with or without colistin had a non-inferiority endpoint. And if you see cure rates in the intention to treat analysis, Aztreonam Avibactam with or without metronidazole have a higher, slightly higher rates of cure rates in case of eradication of pathogen in these cases, and even same thing was observed in HAP and VAP in this particular set of patients. This is another trial which is called as Assemble, and this is a very small trial, and this is a prospective randomized multicenter open label trial on 12 locations, which is still ongoing. And the initial data from this study showed that the ATM AV V plus minus metronidazole combination was better. The cure rates were much better than best available therapy. So ATM AVI patients experienced side effects which were in line with those of the patients who were on Aztreonam alone. So we do not have a very huge antimicrobial armamentarium right now with us. So we have a lot of molecules in the pipeline, and we are right now struggling with a problem which is MBL, and these are the current antimicrobials we are having. So we have ceftazidime tazobactam yet not available in the country. We have ceftazidime avibactam, but we're struggling with the covering NDM and the efflux mechanism of Pseudomonas. Then we have cefepime-zidibactam is still in phase 4 trials, and it is expected to come. However, it will not still cover Acinetobacter. We have meropenem vaporbactam, which is not covering OXA48, immunorebactam not covering OXA48, and NDM as well. Aztreonam avibactam, it will cover NDM, however, less susceptibility against MC, and that has to be really watched for. I think as we use it more in clinical situation, we'll get to know how many MCs are susceptible to Aztreonam avibactam. And yes, if minority of Pseudomonas efflux mechanisms, probably Aztreonam avibactam will not work. And we have then irawacycline, plasmomycin, and cefiderocol, which is yet to come in the market. So this is just an overview of our current armamentarium and place of Aztreonam avibactam in current therapy. So I think we have Aztreonam avibactam has a little better place than all other molecules. So if I have to summarize the presentation, I would say ceftazidime is not active against MBL, and including it for targeting MBLs poses a risk of unwanted neurotoxicity, especially in the patients with chronic kidney disease. And there are a lot of case reports where patients with normal creatinine also develop neurotoxicity because of ceftazidime. So without ceftazidime, and if you want to really bump up the dose of avibactam in serious infection to protect Aztreonam, it is possible with usage of Aztreonam avibactam combination. And it is very novel idea to combine a molecule which have a discrepant PKPD indices, but that can be definitely achieved with excellent bactericidal effect with prolonged infusion and giving it together. This combination is non-inferior to meropenem colistin or best available treatment in initial trials. So it looks very promising. So, and continuous infusion, as I've already stressed upon, is very important with avibactam, which is very important for pharmacodynamic compliance. Both the drugs are excreted through kidneys, and hence dose adjustments are very important. So the chart which I have already shown should be available in the phone or ICU every time, so that there is no mistake, because pharmacokinetic indices or pharmacokinetic targets are very tight, and we have to achieve it to have a maximum bactericidal capacity. So I would end here, and this discussion is just a beginning, and we can have questions and answers after this.
Yeah, Thank you, Dr. Nitin, for that overview of the role of and probably reinventing Aztreonam role in current antimicrobial resistant era. So we have both Dr. Sandeep Reddy and Dr. Majumdar. Can we have them on board? Can they switch on their mics?
Yes, sir.
Yeah. Antimicrobial Stewardship Committee of Ramaya Medical College and Ramaya Memorial Hospital, Bangalore. We welcome you on board, Dr. Sandeep Reddy, for your input.
Thank you.
So, Dr. Soham Majumdar is both intensive care specialist and also a fellow in cardiology. So he works for Kolkata Hospital. So we welcome both of them. Dr. Sandeep, you're just beginning to talk about regarding the presentation. So I find two, three interesting areas which I also felt a part of learning. Those are about a PKPD balancing.
Very much.
I understand it correctly. The Aztreonam Avibactam as a combination molecule, like what we have seen, ceftazidime Avibactam, was on pipeline for the last 7 years by the same company who actually brought this ceftazidime Avibactam.
Yes.
And we were expecting it to somewhere in 2020-21. But during that COVID period, I came to know that there were some concerns related to balancing this PKPD in the same while, and they have to actually go back on that, and they're still struggling to bring it back. And there is a lot of, I think, analysis going on, what I understand. So right now, what we have on plate is both the drugs are available separately. Till recent times, we had only ceftazidime Avibactam, and then used to combine that with an Aztreonam. And the ceftazidime was coming as an extra to most of our patients, which was most of the times as unwanted. So 2 beta-lactams along with the Avibactam use. We only wanted Avibactam. Now only advantage is Avibactam is available as only a mono molecule. So we have a freedom of combining with Aztreonam in a different combination. So on this process, what I take a few points from Dr. Nitin's presentation, sir, the pharmacokinetics and dynamics interplay, and he spoke about some loading doses which are different from what we currently use. That is a grams combined with maybe 600, 625 or 670 milligrams. That is more than a half a gram. So if you really need that, probably you need that molecule separately. It cannot be given in a 2.5 grams of insight of that, Dr. Sandeep, if you really wanted to comment on that.
Even when the combination of ceftazidime Avibactam did come, and then we started adding on Aztreonam, exactly the same thoughts about we used to wonder why ceftazidime was actually kind of combined with Avibactam. Probably my understanding goes about probably the team was looking very specifically for against the HDR and the XDR pseudomonal infections, and our ceftazidime was the front runner for it. Probably that my understanding why ceftazidime was added along with the Avibactam, and then Aztreonam was pushed in. Otherwise, it was the main interplay between the Aztreonam and the Avibactam that kind of gave us the edge over the NDMs that we specifically in our country, in our ICUs that we used to face. Exactly as you clearly mentioned, the company, the main innovator company, were also thinking about combining the both because of the PKPD issues. They're still struggling. They still haven't come out. Clearly, as stated by Dr. Nitin in his slides, you need to have two different infusion pumps with the doses being different, the time of the infusion, the length of the infusion, duration of the infusion kind of not going along with it, because the AUC for both of the drugs are quite different. We need something for our other drug to achieve that good AUC to match with our Avibactam. So there are a lot of PKPD issues that you will definitely come across, and how much can we basis it upon our outcome of our patients in our ICU in a critical care where time is everything is the biggest question. I think intensivists like you will have a tough task ahead, balancing the both. I've heard that Pollen Healthcare is coming up with another combination of meropenem and avibactam. Again, the rationale behind it, we'll have to go back to the boards and see, because again, another amazing pictorial representation by Dr. Nitin in his slides, where how MBLs would counteract and where does Aztreonam helps us in fighting against the MBL. So trying to use meropenem and avibactam against an MBL will again probably fail there. So tough times, difficult questions, as the last slide said, the questions that need quite answering. So Dr. Nitin, back to you. Just for that, how would you counteract? Because I would then, in my ICUs, with the help of my clinical pharmacist and the critical care team, we would have two different lines. Loading doses completely different, and the duration of the infusion different, just to match the PKPDs of both the drugs. So just wanted to probably hear your experience if you've started anything of those sorts at your healthcare center.
Yeah, so I'll talk about that. So in the beginning, you spoke about ceftazidime, why ceftazidime was combined with avibactam when it was actually not required, because the experiments with ceftazidime started in 2015. The problem there was never NDM. The problem was KPC. So they just wanted to have a good beta-lactam which can cross everywhere, have a pharmacokinetic advantage, go to the brain, go to the sanctuary sites, and extended half-life. So they wanted all those things. So 2015 they started working on that. So that's the reason ceftazidime was there. So I already mentioned in my slide, said our problem was not KPC, our problem is actually not OXA. So we thought, yeah, OXA, we have one or OXA, but our problem is actually NDM. And that's the reason to target NDM, we're using ceftazidime, which is, I'm seeing so much of neurotoxicity ceftazidime, because those patients suddenly develop neurotoxicity and you do not know. They go under an MRI, they go under CSF, and everybody's scratching their head why this patient is encephalopathic. Then I get a call, or suddenly they understand that this is ceftazidime which is making all the fun. So that's the reason it is unnecessary. I completely agree with you. Number one. Number two, there is a dramatic difference between the older BLI and this BLI. So older BLI, there is no problem combining with them with any beta-lactam, because their action is limited. So you just combine them, and their half-lives are similar, and then it's easy task. But here it is completely different. It is reversible beta-lactamase inhibitor. So you want it to regenerate. You already want to regenerate. So it is regenerating. It is again inhibiting the Aztreonam. So it is very, very dynamic molecule. And that's the reason it has to be given in continuous infusion. So this is a very innovative way. They tried to find out the solution to this, but they could not find out the company which is trying to combine these two molecules together. So they did not find out how to do that. So that's the reason they have preclinical studies. They have advised continuous.
In fact, they failed in combining. I was with the team.
Yeah, because they failed because the PKPD targets are different, both the drugs.
So this just to take the questions, because the audience questions will be a little maybe different from what we are discussing.
Yeah.
Polen team, can we actually take any audience question if anyone wants?
Yes, we got a couple of questions. That what are your current challenges in managing multi-drug resistance gram-negative infection? And how frequently do you encounter case of infection caused by the CRE? So these are the major questions which I have received right now.
So we will take those questions. Dr. Sandeep, do you want to answer the first question? What was the crunch?
What are your current challenges in managing multi-drug resistance gram-negative infections?
So right now, if I put the question in a proper format, the crunch right now is carbapenem resistance. So if I have a gram-negative bacteria and I have a carbapenem resistant, then I have a challenge. I think that's the crunch right now. Till a gram-negative bacteria is sensitive carbapenem, we had a luxury of using it in an appropriate way and We know how carbapenems were excellent drugs in a beta-lactam group, which used to have such a good penetration, safety profile, and the clearance rate. But now, once the carbapenems are resistant, we are in a crunch. So we'll take Dr. Sandeep's talk, how you are handling a carbapenem resistant gram-negative bacteria. We will again classify whether they are maybe are they what to say, the crabs, the carbapenem resistant Acinetobacter or Pseudomonas or SCREs. That's a different question. But carbapenem resistant, do you agree carbapenem resistant is a real challenge right now?
Very much so. This CREs have always been an issue in the recent times among all ICUs across the country. Now, the challenges that we would probably face in back at all our healthcare centers is what kind of a combinations that we would come across to tackle such CREs, and then it comes to where the source of the infection is, whether it is a respiratory source, origins, is it our hospital, the ventilator associated pneumonias, where Acinetobacter, the CRAs have taken up the upper hand among our VAPs, or is it our whether we're dealing with these in our catheter associated UTIs or in our surgical site infection. Things goes really bad with the abuse of antibiotics that previously the patients would have had. The moment we face such an issue, it all comes down to what kind of a combination of drugs. But then you're looking at a critical care patient where their renal clearance is already done, probably secondary to main sepsis, hemodynamic instability. So that brings another question, a challenge in trying to dose your antibiotics and the selection of antibiotics that is left, whether with our digicyclines, and then your last resort where you would want to hit the ceftazidime, avibactam, and the Aztreonam combinations. We do, most of the times, we do get away with our polymyxins B very much, with plus or minus an addition of an aminoglycoside. But in critical states where a few of our, in discussion with the critical care team, we've used the combinations of, again, a carbapenem plus an EDTA, where our patients are not in septic shocks, we're not in MODS, but my punch has grown, a carbapenem is resistant to Enterobacteriaceae. But with the use of meropenem and an EDTA, we've been lucky among a few set of patients where we didn't have to go up the order escalation of antibiotics, or the worsening of the patients are not seen. So basis on the differentiation of the clinical picture of the patients, a carbapenem plus an EDTA, if our patients are quite sick, we would then escalate to polymyxin B related plus aminoglycosides or tigecycline, and then if I'm dealing with an NDM, we would definitely then stop everything and just go down with the usual ceftazidime, avibactam, and the Aztreonam combination. So this is what we usually kind of prefer at our center.
I think very accurately put forward. Whenever we come across any gram-negative bacteria which is carbapenem resistance, we look at both the source and the organism. In the sources, what we have found in this part of the world is that if it is a respiratory source, VAP or a pneumonia, in a hospital who already is receiving carbapenem and you are seeing a resistance, more common is Acinetobacter followed by Klebsiella and Pseudomonas. E. coli is extremely rare.
Very rare.
Whereas if you look at the other areas, like if I look at a urinary pathogen, we find Acinetobacter being extremely rare. E. coli is a primary pathogen, followed by Kleb, and maybe some of the cocci grow there. When it comes to CRBSI, Kleb leads the front, yes, and followed by sometimes you see other CREs also. Extremely rarely we see Acinetobacter also. So this is the pattern which we see. Now the question which Dr. Sandeep was trying to answer is, whenever we come across the CREs, the usual final destination used to be colistin. In the last 5-7 years, we used to actually go to the polymyxin B or a colistin, one of them combining with tetracycline or a minocycline based on Acinetobacter or non-Acinetobacter. But we all are aware colistin and polymyxins were extremely toxic drugs. Their kinetics and dynamics were very challenging, nephron neurotoxicity, much higher than what we were actually discussing about ceftazidime alone. So we were all had no options, but were using in the combination. And some of us in the early parts, in maybe 2014-15, used very high doses of meropenem in a thinking process that higher dosage of 2 grams IV TID may help us. But later on, we realized that most of those drugs, when your MICs are more than 16 or 32, they were all not of any use. So we dropped those ideas. So these were all experiments and therapies which we used to do. But of late, once this Avibactam was available, and we have a data that if I have a CRE and it is an NDM, so I have another option now called Avibactam in combination with Aztreonam. Because they were not available together, we used to combine. Now we are having an availability. So all these CREs, this option comes. But in the CREs also, we have again divisions, whether it is a Klebsiella, whether it is an E. coli, whether it is an Enterobacter, whether it is a others group of Enterobacteriaceae family. In that Kleb, what our pattern is, we see a good amount of Klebsiellas has a synergy positive later on after empirical. But the same pattern is not even seen in E. coli. We see a good percentage of our Avibactam Aztreonam are resistant to E. coli. So these are the things which we are seeing, which actually Sandeep brought out. EDTA as a molecule or a resistant breaker, which has been used by some of our Indian colleagues by an Indian molecule. But yes, there is a limited pockets of information like experiences with Dr. Sandeep said. Over to you, Soham Mazumdar. Can you just come on to the board? Any comments on this part?
Other things, sir, everything is fine. But two things I just have to know. When Sandeep sir is talking about the meropenem along with the EDTA, but is there any synergy you clinically found it? Because in the practical situation, when it has been tried with the meropenem with the EDTA, it requires us to make the synergy. 1 gram of meropenem is required almost 1,000 mg of the EDTA, and that will be a supra normal that cannot be used. The standard 37.5 or 75 mg of the EDTA is only found the PKPD synergy with the ceftriaxone or ceftriaxone sulbactam. So when you are using a EDTA, is it only a ceftriaxone sulbactam EDTA, or is the meropenem plus EDTA simply other combination?
Dr. Soham, I will deliberately try to probably said that question, saying that our discussion is to focus on the use of Avibactam in as a molecule and rescue the Aztreonam. As you rightly said, there were been discussion related to EDTA's dose requirement in any combination, but this is again a personal experience and very small pockets of information, and none of the standard guidelines even came across with that. So we'll probably take it as it comes. At this point of time, I think, as you rightly pointed it, we don't have a dose. EDTA was available separately. So any other questions from the audience?
Sir, there are two questions is from Dr. Vinod Gosavi. What is the strategies when both OXA and NDM with E. coli and Klebsiella? And what is the strategy when both OXA48 and NDM are detected with E. coli and Klebsiella? So how you gonna deal with this scenario?
Dr. Mazumdar, do you want to actually talk about it?
NDM producing E. coli is very less in our country. It is practically speaking. So yeah, it's OXA, MC and OXA co-production of the E. coli is much more higher. NDM and obviously MDM OXA producing CLEP or NDM or MC producing CLEP or CTXN producing that, this combination will be higher in the Klebsiella. And for that purpose, if it is a pure Klebsiella, though there is no, personally we are not getting the Vitek value from the lab for the Klebsiella bloodstream infection purpose with the Ceftravi or Aztreonam independently, we have to go for the synergy test, definitely, every patient. And if the synergy will be positive, then the Ceftali-Aztreonam combination will be better for the any blood because the PKPD is much more linear with the bactericidal effects. But the E. coli part was still the NDM producing E. coli is quite less in our country, the inter part. So I think the E. coli will not be the problem. The problem will be the Klebsiella with the co-production of the NDM and other either Oxa or MC or the CTXN.
Yeah, absolutely. The clear answer is if it is a Klebsiella, you can use the ceftazidime Avibactam Aztreonam in combination. If you have plain Aztreonam with Avibactam, that can be a point, but you need to have a cross check with synergy. But if it is an E. coli, then empirically using this combination looks very, at this point of time, looks a little dicey because there's a good percentage of resistance to current ceftazidime Avibactam or Aztreonam combination. So in E. coli, we probably will not rely much on ceftazidime Avibactam or Aztreonam Avibactam in combination. But the other question is, if it is only Oxa or if it is an NDM, so what do you do if there is a both the things? What you will do for only Oxa? Probably ceftazidime Avibactam alone will be enough if there is no NDM. But if there is Oxa and NDM, which is a common pattern which we see in India, then probably we need Avibactam plus Aztreonam together. One will not suffice in those situations. And any other questions?
No, sir. From the chat box is over. Now the forum is open. If anyone has any question.
Any comments from your side related to E. coli?
E. coli endiums, we do see E. coli endiums, and the problem with E. coli and Pseudomonas, these two organisms, that they have multiple resistance mechanism.
Yeah,
So
absolutely.
it's not only beta lactamase. So they
Yes,
have
yes,
efflux
absolutely.
comes, they have foreign mutations, you know. So and that is the whole reason that Aztreonam Avibactam or Ceftazidime Avibactam Aztreonam combination may not work in E. coli in many situations. So we have to be very, very careful remembering this fact. And definitely you must do a Karba, see what is happening. And our primary focus now is NDM. So we don't need ceftazidime actually. So Aztreonam Avibactam is actually treatment for the patients who have OXA48 and NDM both.
Okay.
Okay. Specifically, I am asking also for the Pseudomonas. The last Pseudomonas data of our years also is the same. The efflux ion mechanism pattern resistance is much more the higher rather than this NDM or OXA pattern. So probably the Ceftav is not the good choice of our multi-drug resistance MDR Pseudomonas also nowadays.
Agreed, Dr. Majumdar. It is true for even Klebsiella.
Yeah.
See, if suppose you do a Karbar and you don't find any resistant mechanisms on your enzymes pattern, no CREs or no NDM, no OXA, but your carbapenem is resistant, that means indirectly you know it is not based on beta-lactamase based resistance. There is a efflux or a porin. So obviously none of your beta-lactamase inhibitors will work there. So again, unfortunately, we have to rely on either a polymyxin based therapies there in those situations.
I have another
don't have any mechanism at this point of time, commercially available mechanisms to even know. It is just that enzymes are absent, but carbapenems are resistant. We just probably consider it to be having one of those mechanisms.
Yeah, unfortunately, you have to add polymyxin in these patients.
And
this is I have a question.
Yeah.
I have a question. This is as per this Aztreonam Avibactam combination, probably that will be the best time over MIC, right, sir? Rather than the Cemax over or AOC over, because there is
it's more of a time
dependent. It is a
that's why the continuous infusion and the 6-hourly timing dosing, that will be the So what is the presence of the loading dose regarding that?
Okay, how are we practicing? We have been practicing this when there was no availability of even Avibactam in alone. We were doing it for the last maybe 5 years or so. The pattern we do is we load Aztreonam 2 grams in a 50 ml syringe, and we load 500 milligrams of Avibactam in a 50 ml syringe. Both the syringes are parallelly connected with a 3-way going to a patient, and this will be given around 17 ml per hour, so that 50 ml syringe will be over by 3 hours. So that's what we made it very simple to the nurses.
Yes.
Load it in ml, give it over 3 hours. So they get confused. 15 ml, I say 50 by 3. It will come somewhere between 17 ml, start 17 ml. That will be over by 3 hours. So that is how we used to manage for the last 4-5 years.
Okay.
Yeah, I think that is absolutely correct.
And what is the thing of the loading dose? Why there is a loading dose if it is time
So
or
there
whatever?
are, Dr. Nitin has presented a loading dose where both has been given, the 2.5 grams in fact of azithromycin, and also the loading dose of 600, maybe 25 or 30, Dr. Nitin as a Avibactam. So
Yeah,
that is
so
probably
we can actually round off that dose. So for example,
so
if
that
it
is
is
the best
600 and
combination.
you are seeing a very sick patients on multiple inotropes, you can round off it to if 670, you can round up to 800, or 700 as per the situation.
So the other thing is, in that loading, we ideally do in the order of first Avibactam followed by azithromycin.
Yeah,
Not azithromycin first by Avibactam. If you
correct.
give azithromycin in front and then you load Avibactam, your azithromycin is destroyed. You just give a beta-lactamase inhibitor followed by Avibactam, maybe subsequent or a conjugatively one after the other, but the first will be azithromycin followed by that. What we do right now, we use a 500 milligrams to a gram of Avibactam. These are all, I think, evolving areas where if your synergy is doubtful, your resistant mechanisms are also growing up for Avibactam also. Instead of that 1:4, the combination right now we are using is azithromycin ratio Avibactam is 4:1. 2 grams, 500 milligrams. We are trying to see whether if increasing in Avibactam, that's a gram is to 2, that is 1:2 ratio, is it helping? In some of the cases where we are not finding a clinical response, but these are all experimental. We don't have any robust scientific data at this point of time. But what Dr. Nitin has shown, 600 plus milligrams for a 250, 2.5 grams loading. So that is a way ki if you have a sick patient, load with maybe 500 milligrams and another 100 or 200 milligrams more of Avibactam.
Yeah, you can round off to a higher dose rather than a lower dose.
So what is your roundup dose, Nitin? That's
Round off,
what.
sometimes I do 1 gram also. There's no
Yeah,
problem.
exactly. So the roundup is you have availability of 500 milligrams Avibactam. So I give 2 Avibactams along with maybe 3 grams of azithromycin as a loading in a patient where my volume of distribution is locked up because the patient is shifted after 6-7 liters of fluid. So we load with 2 grams and 3 grams of azithromycin and Avibactam of a gram, and then followed by we continue the infusion. But the infusion which we start is not at the end of 8th hour. We start is earlier of that 8 hours. That is after the 5 hours I start and I continue that gap of 8 hours later. So that by 8th hour, the second dose is gone.
Yeah.
Yeah, I think this is amazing. This is what everybody must know.
Yeah, as Dr. Venkat mentioned, yes, the most common amateur mistake that they do with the loading dose and they think the next dose is at the end of the 8 hours they miss and they usually, they
So the problem
go
there will
wrong
happen is the dose will end at not at 8th hour, but the dose will end at 11th or 12th hour.
11th or the 12th.
So by the time if you have a sick patient, I think you lose that MICs. So what we do, we load and then we start the next dose at the end of 5th hour, so that by end of 8th hour, your second dose is in, and that continues again. From there it continues.
So, Dr. Venkat sir and Dr. Nitin, again, coming back to the previous question about Oxa E. coli, we've tried with adding fosfomycin at our center. So, your take on those? How fosfomycin, specifically with Oxa?
If I have a patient with urosepsis, pyelonephritis, bone and joint with an E. coli where my penetration is good, we use fosfomycin on front. The dose we use is 4 grams every 6th hourly. That's around 24 grams. We look for sodium, we look for volume. These are the two problems which we face. Sometimes the E. coli generally, which is 90 to 100% susceptible to the fosfomycin, rarely during the treatment may get a resistance. So we keep the other things on, but the fosfomycin for a urinary tract will be one of our choice available. If I have to give something,
Fosfomycin is always a supplementary drug, It is never a backbone. And a lot of E. coli can have a FOSA gene, which enables resistance to phosphomycin. So you have to really see if you have a dramatic response to phosphomycin, because it has a lot of pharmacokinetic advantage, is very high volume of distribution. So if you see initial 24-48 hours of therapy, if patient is improving, it's really worth. And as sir said, that it can just pick up the resistance during the treatment. So these two things are very important. Otherwise, rightly used, it is one of the very good drug.
The other option, if you really want to use empirically, will be again colistin, not a polymyxin in urinary tract infection. And tigecycline again will not have any penetration to the urinary tract. So you have very narrow choices there. So either this or otherwise that. So that's where we are. So I think we will take a take-home points, Majumdar sir, a wonderful, interesting insights from you, your experience. So any take-home?
Yeah, definitely. What after this gross higher presentation from the Nitin sir is definitely the use, how to use the drug, this Aztreonam and Avibactam. That will be very much important to know everyone's the duration, the process, and the ability to when to use it, and take the early decision. First one and the bug choose regarding where to use the combination with the Ceftavi Aztreonam, what to use this Aztreonam Avibactam, what to use the polymyxin mix combination. That is the number one. My take home from here, number one. And number two, obviously, when still the drug without a combination in presence of us, how to use it. When it will be available in the market as Aztreonam Avibactam combination, then that will be a different issue. But apart from now the recent situation scenarios, how to use it in detail, apart from this ceftazidime combination, also that will also be important to know for everyone to know. Number three and number four is the bug distribution. I hope the entire situation, your part, Venkat sir, Sandeep sir, Nitin sir, every hospital, the local epidemiology is the different. So what is the empiric? Even if the culture is not come, the very sick patient in your ICU, you send all the cultures. Probably it is in the patient stayed in the ward. Patient was probably in the other surgical group of the patient, shifted to the ICU in a code blue cases or something else. But will be the empirical choice. That will be also a discussion point probably, because patient, I just received a patient from the ortho ward just one day back, having a bilateral TKR, so much more comorbidities. Patient was on catheter, followed by a vomiting, no possible from it's a COTI, followed by an intraabdominal infection. Also, probably it is not being evaluated completely still. Then what is the patient already was on 2 or 3 antibiotics from the wards, from the general medicine ward glucose. So now it is in the ICU under our care. So should we use in our country regarding this part? Empirical Ceftavi Aztreonam should start or not? That will be our discussion thing also.
So yeah, I think a very interesting discussion. If any patient in your hospital, your epidemiology, your antibiogram is more important than guidelines and all this discussion. But the common pattern, I think what we see in India, which ICMR also released, where I have actually was going through the 2024 ending guidelines, it remained to be the same. If you have a VAP or respiratory infection, more or so across India, the common pattern is Acinetobacter is the leading, followed by Kleb. But whereas in bacteremias and other intraabdominal infection, Kleb leads in urine, and as a gram-negative bacteria, E. coli is the leading. But yes, as you said, your own hospital data prevails over all this information. These are all background information, but your hospital data obviously. But as you rightly questioned, if I have a patient who already received carbapenem and maybe also received some of those combinations of glycopeptides or a metronidazole for some intra-abdominal infection or a COTI, now is in your ICU with again in an organ dysfunction with a sepsis and shock, probably I will not hesitate to consider a escalation above that, considering a CRE there. Either in the form of, if I look at intra-abdominal infection or a bloodstream infection or a patient with a TKR, a skin and soft tissue infection, probably I will think both of CRE and a coverage of those which can actually cover MRSA or those cocci which can actually resistant to any of your regular coverage. The second part will be if I'm looking for a aspiration and a hospital acquired pneumonia, and my hospital has a propensity of having Acinetobacter, I will not hesitate to consider a polymyxin based therapy on that side. So I know we are overboard, but unfortunately that is where we are. To be very honest, that's how we are handling now. And once the culture report comes back, the patient gets stabilized, you optimize. But at that point of time, you will not have time. So that's how I think we are managing at this point of time, Mazumdar sir. We have a difficult time, but that unfortunately, that options we have left with. And right now, we are seeing one more pattern. I don't know. I will probably take this opportunity to ask Dr. Nitin and Dr. Sandeep also. Most of our Acinetobacter, where we used to treat with polymyxin plus minocycline, seeing a pattern where minocycline is getting resistant more and more, and TG has been sensitive yet. Is that same pattern? I don't know whether we are observing, because we used to prefer Mino over TG for Acinetobacter. But right,
Yeah, correct, sir. This is what we are seeing also. And that is extremely important, because minocycline, you have to really use high dose minocycline or high dose tigacycline in these kind of cases. So yes, this is a pattern, and cross resistance is not common in tetracyclines. So
right now we have switched from Mino. If my Mino is resistant, we are using TG in the double dose, because that's what is. So again, this is an important, Mazumdar sir, as you pointed out. What is happening in your hospital? We are talking to other colleagues that is the same pattern you are also seeing. Then if that is true, then what we used to follow, that for Acinetobacter polymyxin plus Mino were the choice. Now we are changing our mind when my hospital Acinetobacter is showing more resistant to Mino. Then we are switching from Mino to TG. Yes, we know TG may not be a better drug, but unfortunately we have that option. But for lung, we double the dose.
Yeah, definitely, sir. We have the same propensity of having a minocycline when we are using for the Acinetobacter. It's a crab VAP or something. So, and the Mino probably, and the second, if the second culture also positive, is obviously resistant to the Mino. But the issue is that if it is a VAP only, we are just thinking about if we want to use Mino, lung alveolar self penetration is much more higher. So should we think about to use a double dose of Mino rather than double dose of TG? Should be a better thing.
Yeah, it's again a question of comparing both of them in double dose of Mino or double dose of TG. We are now seeing double dose of
our experience, double dose of TG patients
agreed. Your point is well taken. Whether you can increase the dose of Mino, and because it has a better penetration and better coverage for Acinetobacter, versus a sensitive antibiotic in a double dose with a lesser penetration. Yes, you can weigh in. So any takes on that, Sandeep Reddy sir?
Almost the same thing, sir. Almost the same thing. Where again you're looking at a tigecycline, which might not have penetration in your lungs as much as what minocycline would have given it to you, but giving it a higher dose against its side effect profile of hepatotoxicity will always be in the back of our minds when we are treating such the carbapenem resistant acinato. It is, we've been lucky at very several times that TG has worked for us. Otherwise,
for us. I don't know.
TG's worked for us.
200 milligrams loading, 100 milligrams
and 100 milligrams BD twice daily, probably 7 to 10 days, and we've extubated our patients. They've all gone home. But yes, that has been the rising concerns now. The acinatos have become more smarter, and we're just now catching up with them. So, yeah, we're trying to probably come up with
on that.
Yes, sir.
Any points on that?
Yeah, we have very few drugs actually to treat MDR Acinetobacter, or difficult to treat Acinetobacter. So polymyxin tigacycline is your classic. Then you have sulbactams, which can be used in high doses for these patients. But Acinetobacter is one infections where, in spite of treating them with full antibiotic sensitivity on all, using all PKPD attainments, still mortality is very high. So
we request Poland to come back with darolabactam and sulbactam. I think
cefiderocol is the answer.
Avibactam-based
4 or 5 times.
Avibactam. So we request Poland Health to bring that. So we are now using sulbactam in combination, either in it alone up to maybe around 8 grams to 12 grams, or we use an ampicillin sulbactam if it is not available as a therapy. But I think there are some reports that darolabactam combination has been proven to be superior compared to the colistin based therapy.
Yeah.
So we over to you. Any final comments, both Dr. Nitin and Dr. Sandeep?
No, sir. You've placed it well, sir. So I don't think I've got any more further
In
words.
my clinical experience, sir, I used a cefiderocol 4 or 5 times. I brought it from the US post-COVID times. It's an excellent drug, but I had a different time discussion with this. It is from the Shionogi Pharma, Fetroja. Different times, but they will not give any permission or permit to come this to the country. That is the problem. But it is, as per the Nitin says, it is excellent drug to use. Excellent.
Yes. Cefiderocol will be one of the dream drug to come, but the problem we already started seeing in the West. It will cover Acinetobacter, it will cover all CREs, it will come NDMs, all that Ambler group which Dr. Nitin spoke, and all the bacteria. The problem is we have already seen in the West where it is used, it is during the treatment period also, Acinetobacter has started showing resistance to it. Any antibiotic which will be used will have some or the other challenge. Which
I have one of the best treatment for Acinetobacter, and Dr. Sandeep also knows that is infection control. So by using infection control, you can bring down Acinetobacter to baseline. I have done that in one of the hospital where Acinetobacters were floating around 35 to 40%, and just implementing a stricter infection control policy, they just came down to 16% in a year in the entire antibiogram. So antibiotics cannot do that. I think it's only infection control which can do that.
True. Over to you. I think we are coming to end of the session.
Yeah.
Over to you.
Yeah, okay. So on behalf of Poland Healthcare, I'd like to say thank you for your valuable time, Dr. Nitin Shinde sir, for speaking up on a very special topic, the revival of Aztreonam with Avibactam, redefining antibiotic treatment. And as being a very gentle and very humble moderator, Dr. Venkatraman Kola sir, thank you so much. And the very excellent participant, Dr. Panelist, Dr. Soham Majumdar and Dr. Sandeep Reddy sir. So on behalf of Poland Healthcare, I'd like to say very thank you so much to all of you for joining and putting some inputs regarding these two excellent Aztreonam and Avibactam. Thank you so much, sir. Thank you for your valuable time.
Thank you all. Thank you, Dr. Nitin, Dr. Sandeep.
Thank you.
And all participants.
Thank you, madam.
Good night.